So let's talk about addressing femoral defects, stem selection, and revision total hip. This really comes down to stem selection. These are my disclosures. We have less ability to reconstruct bone on the femoral side. A lot of these acetabular bad defects you've seen, a lot of them are somewhat contained, lends itself a little bit more to reconstruction. It's a little harder on the femoral side. But we all know that more hips are being done, and of course that leads to an increase in revision total hips. It's estimated now that about 15 to 20% of all total hips are revisions. Of course they can be difficult and complex procedures. But we have multiple options to try and gain fixation. Cement fixation, we have cementless with proximally loaded stems. We have fully porous coated stems. We have fluted tapered, the Wagner type stem. We can use impaction grafting, allograft prosthetic composites, and then proximal femoral replacements for massive bone loss. And the choice of your implant really depends upon the available bone for support and where the defects are. There's a number of classification systems that can be somewhat helpful. Our academy has a system that's based mostly on whether it's segmental or cavitary defect or combined. Mallory has a system based on whether the cortical tube's intact and the extent of deficient cancellous bone. But the most common one, just as it is on the acetabular side, is Wayne Proproski's classification. Type 1 is minimal loss of metaphyseal bone. The diaphysis is intact. This is almost like a primary hip. Type 2 has more extensive loss of metaphyseal bone, but the diaphysis is still good. Then we have the 3A, where the metaphysis is really not supportive, but you have a good diaphysis. And a type B is the same as a 3A, but you have less than 4 centimeters of isthmic fixation available. And then the type 4, you really have minimal bone available for fixation, either proximally or distally, mostly because the canal distally is very widened and ectatic. And generally speaking, what's important is where do you have bone to gain support for your fixation? And the Proproski classification is generally the most useful for implant selection because that's what it really turns out to be. So we can reconstruct some bone, a little bit about femoral struts. You can reconstruct the femoral tube with these. If you have thin, unsupportive bone, you can use them. You can bridge a segmental defect. I often use them for reinforcement of a fracture that I fixed, or if I made a long ETO, I'll put one on to reinforce that as well. Choose a strut that has the correct bow. You got to look at these before you open the package up. It needs to match the native femur. You have to radius this out. You can see the large end of the graft there. That'll fit on the femur, but the small end won't. So I usually take a large pear burr and radius that to enlarge that so it'll fit down flush on the underlying femur. I usually coat it with morselized graft, or we often use the demineralized bone matrix to kind of take up any defects. And then I fix it with simple wires, or if I need stronger fixation, I use braided cables, but the wires suffice most of the time. So type 1, these are rare actually. This is just a loose grit blasted stem that somebody put in for a fracture and it never got on growth. And you can treat that like a primary hip. Basically, you can do almost whatever you want. You can even cement it. But even these have a sclerotic endosteum, so if you're going to cement on these, I think you need to get rid of that. You take a burr and get rid of a lot of that sclerotic bone so you can get some cement interdigitation. I just used an SROM. I was aggressive with the reamer proximally. That's basically a primary hip. Here's another type 1. This is an SROM that I did. Failed to ingrow. I don't know that the ASR had anything to do with that, but I don't have many SROMs that don't ingrow. But since he already failed with proximal ingrowth, I went ahead and put a Wagner type stem in, and again, it's very simple. It's like a primary hip. Type 2 are more common, and we often see these when we have a cemented or a cementless stem in the early stages of loosening. They have cancellous bone loss, but the metaphysis is still supportive. And lots of treatment options. Again, you can use a proximally fixed stem with a distal fix, or proximally ingrown stem with distal fixation like an SROM. Fully porous coated stems, i.e. the AML or solution, work well. Wagner stems are good. Beware of proximal femoral remodeling. In a case like this, you don't have it. You see that shoulder was starting to bond from the cement. And I did an ETO to help with cement removal, and then I was able to just place an SROM. Quite simple. But in this case, this one's a little bit farther along, and you can see that there's significant varus remodeling to the proximal femur. You're not going to get a stem down that without doing some kind of an osteotomy. So we do an extended trochanteric osteotomy, allows us to get a straight stem down, and then I've protected that with the femoral strut. The type 3s, again, the metaphysis is not really supportive. You need distal fixation. kind of the same options. Wagner stem works very well. I think now that's the easiest stem to use. It used to be that maybe a fully porous coated stem was the easiest, but now that we have modular Wagner systems like the Reclaim or Restoration, it's made this very easy. We can impaction graft. I think it's more technically difficult, takes a little more time and resource. If you don't do this frequently, I think you may have a higher complication rate because it's a bit technical. But you can use it when you can't gain fixation by standard methods. You can consider in a young patient, it's actually a biological solution of a sort because we're increasing bone stock. A few tips about this: you have to be able to convert uncontained defects into contained defects, usually with mesh. You have to have axial and rotational stability. You use a collarless, polished, tapered stem. That allows for the controlled subsidence. You can induce hoop stresses, and that will allow creeping substitution in the bone. You can have, and eventually you get living bone, but it's quite a long process, and you have to protect the patient for quite a while. So this is probably a type 2 on your left, and the defects are closed with the mesh. A long stem is used just to bypass the thin cortical area that you see, and then it's standard impaction grafting. On your right, that's probably a 3A because there's a big metaphyseal defect, but able to reconstruct that with mesh, and then you can use a standard impaction grafting technique. This is a 3A that was secondary to a fracture, unrecognized intraoperatively, and then they show up with a subsidence and loosening, but this is subtroch fracture basically, and so the fracture is fixed, but this is basically a modular AML stem, if you will. It's a fully porous coated stem for distal fixation. Another type 3, you can fix this with a Wagner type stem. They're very useful. If you have reasonably supportive bone distally, you can pot that wedge down in the diaphysis. This is a 3A, maybe a 3B. There's very little bone proximally. It's mostly cement. And so you have very little support. Distally, it's somewhat of an ectatic canal. It's a low demand patient, so you can cement. Not the greatest cement mantle distally. It's difficult to pressurize when you put such a long stem down, but with such a long stem, you still have very adequate stability. 3Bs are severe metaphyseal damage and maybe some disruption of the diaphysis. This is probably a 3, getting close to a 3B. It's a difficult situation to get reliable diaphyseal fixation. Again, the same options. Wagner's, you can use a solution stem, but if you have less than 4 centimeters of diaphyseal fixation, the risk of fibrous union or fibrous fixation is higher. Impaction grafting, difficult. You have to be able to reconstruct that tube, which can be difficult. That was the case that I just showed you, massive proximal bone loss. Again, a Wagner stem, able to gain axially and rotational stability. Here's a case that was done elsewhere, probably a 3B, very ectatic canal. They tried to do a long SROM and didn't work with subsidence and anterior cortical impingement. That's revised again to a Wagner stem. I included these. These aren't revision hips, but these fractures, I see a lot of them now. You probably do as well. These trochanteric femoral nails are very popular, but they don't always work. There can be a lot of destruction to the proximal femur. The abductors are usually destroyed after they've taken multiple attempts to try to pass this nail, so these can be difficult cases. And if it's an older or elderly patient, which most of these are with the fractures, I just excise the bone, try to retain the trochanter, wire it to the prosthesis, but I get rid of having to have any biology happen. I just put a proximal femoral replacement in these. Type 4, these have extensive metadiaphyseal damage, widened canal distally. The isthmus is generally non-supportive, so they're very difficult cases. Wagner stem may be a femoral allograft prosthetic composite if it's a young patient. You will have to probably do a reduction osteotomy distally or a proximal femoral replacement if it's a low demand patient. So this is a difficult case. Actually, able to fix the trochanter with this long trochanteric plate. The Wagner stem is placed, and the bone is almost soft enough that those cerclage wires almost act like a reduction osteotomy. Even though we haven't made any osteotomy, it can somewhat collapse the bone around the implant and give you stability. So in summary, we have multiple reconstruction options available. You need careful pre-op planning. Appropriate implants need to be available. I think the Wagner type stem is really the workhorse now for most of these situations. It's easy to use. It provides reliable fixation. And now that we have the modular stem instead of the one-piece stems we used to have that were a bit difficult, we can now adjust leg length, offset, and anteversion. Whoops, sorry about that. Go backwards. The proximally coated stems, simple cases, you can use an SROM. Again, decorticate the bone or be aggressive with your reaming. Cemented stems for low demand, and then impaction grafting, if you can reconstruct the femoral tube, that's a biologic option. And for massive bone loss, again, you can always use proximal femoral allografts. Thank you.
Thank you, Dr. Kirk. May I invite the next speaker, Dr. Sunil Rajan, for his talk on the use of modular tapered femoral stems in revision total hip.